Right, now we will talk about the surgical management in the patient with trigeminal neuralgia. As we discussed in previous section, that if medical therapy fails or fails to provide enough relief, or if it is not tolerated well, then we think of surgical options, right? These days there are three popular surgical approaches, right? Let me discuss them one by one. Number one is microvascular decompression. Microvascular decompression. This is one surgical modality. I will go into detail later. Another surgical modality is, yes, that is percutaneous. Percutaneous means through the skin. Percutaneous, yes. Percutaneous radiofrequency. Percutaneous radiofrequency, I will again explain it properly. Frequency, thermal rhizotomy. Rhizotomy. Right? And the last one more surgical approach is gamma knife radiosurgery. Now let me discuss them one by one, and you must know what are the advantages and disadvantages of different surgical approaches, and for which patient which modality is suited best, right? First we go into detail of microvascular decompression. It's the most widely used surgical technique for the patient with trigeminal neuralgia, and let me tell you what it is, what we really do there, right? Let's suppose here is your brain stem, pons, medulla, and yes, of course you know that here is cerebellum, and now I put it here dura mater, right, and behind it there must be skull. Here should be skull, right? Bone of the skull, and of course then you have your skin and maybe some hair also, some maybe lot of, I don't know, it depends on you. Now, where is the problem? Where we have to reach, where the surgical instrument should reach? We need to approach root of the fifth cranial nerve, right? This is your again trigeminal ganglion with its deviance, right? And actually what's wrong there? Yes, this is sensory root of the trigeminal nerve, and let's suppose here's the offending vessel, blood vessel, which is inappropriately compressing the trigeminal nerve root, right? And here is the focus of ectopic action potential generation, which produces the paroxysms of pain, right? In microvascular decompression surgery, what is the purpose of it? The purpose approach in this patient, or purpose is that somehow we should remove this blood vessel from this site in such a way that it's no more irritating or disturbing or compressing the trigeminal nerve root. Now how do we do that? Remember, this type of technique, microvascular decompression, we also call it MVD, right? MVD gives the best result in classical case of trigeminal neuralgia. In previous part, we discussed in the clinical manifestation that trigeminal neuralgic pain can come in a classical fashion, or it may be as a symptomatic case in which there are some other trigeminal neuralgic pain is one of the symptoms of some other disease, like there may be compressive lesions here, schwannomas or meningiomas, or there is neurofibromas, or there is aneurysms of arteries, right? Or what is that? Multiple sclerosis, right? But in those cases, we say that trigeminal neuralgia is symptomatic trigeminal neuralgia. In those cases, surgical intervention may be done except in multiple sclerosis. Surgical intervention may be done in neurofibromas or schwannomas or aneurysms or in meningiomas, but that is different than microvascular decompression. Of course, if there's a tumor there, there's no fun to remove the vessels around the nerve. Is that right? So, first thing which is very important, that this kind of procedure gives the best result in which cases? Patient selection. You will select the patient which have classic tick-like, you can say, episodes of the trigeminal pain. Is that right? Because these classic tick-like are due to vascular compression in most of the cases, right? Now, this is a major surgery. It's a neurosurgery. It's invasive, right? What you do, that first of all, you have to do a craniotomy, producing a hole in the cranium, in the skull. Usually you do suboccipital approach. So we use suboccipital craniotomy, and we open a hole here. Let's suppose here we have opened a window, right? We remove about 3 centimeter piece of skull and we approach. First step, craniotomy. Second step, you open the dura mater, right? Third step, here is also subarachnoid matter, you open that, and after that you slightly lift the cerebellum from your approaching pathway, and you approach, go on the side of the pons, right? And on the way, yes, it's extremely important, yeah. On the way, at pontomedullary junction, here, there are 2 nerves coming out. One nerve is 7th nerve, facial nerve, which is exiting from here, and here is another very important nerve, and this is 8th nerve, 8th cranial nerve or vestibulocochlear. So, when you have done the craniotomy, you open up, what is this? Dura mater, subarachnoid, arachnoid matter, and then lift the cerebellum away from your pathway. Please identify 8th cranial nerve and spare it. Identify the 7th nerve and take care, don't damage that. And then, after identifying them and protecting them from your vigorous activity, move carefully forward until you started your travel from here, okay? You started your approach from here. From here, eventually you reach up to here. Now, with special micro instruments, you will identify the blood vessel. Here I must mention that before the operation, pre-operatively, you must do high resolution magnetic resonance imaging before the operation, so that imaging, high resolution MRI, that can help you to identify the relationship between the offending and guilty blood vessel and the innocent suffering nerve. So before you approach there, you know what you are expecting there. Is that right? So once you reach here, then you will lift the, what is this? Lift the artery away from the nerve, trigeminal nerve root, right? You lift the artery away from there, and of course many times neurosurgeon will see there's a little depression here, and sometimes this nerve has become a little atrophied and it's thin and yellow. But anyway, you remove that artery, right? And you don't want that it comes back again here. You don't want, it comes back. Of course, nerve become decompressed. It become decompressed. It's no more compressed. And in between that, you can put an, you can say an artificial pad, which is made of this is made of Teflon or Decron. An artificial pad is put between the artery and the nerve, so it does not come back and disturb it again.
Yes.
Is that right? Yes. Then of course, very carefully you will wash this with the saline water, and carefully you come out and stitch back the dura mater and then reconstruct all this area. Right? This is the basic approach in microvascular decompression. Microvascular decompression. Am I clear? Now, it's an invasive surgery. It has side effects. It has its own price. Not only you have to see that patient is having classic tick-like symptoms which are due to this. Is that right? I don't want that you find a patient who has trigeminal neuralgia and with that interictal numbness is there or sensory deficits are there. It means this is a symptomatic case, as I explained in the clinical manifestation lecture, right? So in those cases, of course, this surgery won't be helpful. You cannot remove the blood vessel away which is really not producing symptoms. Am I clear? Now, the important thing is that there are important side effects or complications related with this. Yes, you have a question.
It is best for weak patients, sir.
I told you it is best for the classic tick-like patients, right?
Yes.
Okay. Now, what are the complications of the surgery? Right? Remember, you have to use the patients with this type of diagnosis and who are physically fit to go through surgery. Because later on I will tell you that there are other options which are less invasive or not invasive at all. Is that right? But anyway, but this gives the best result. That is why if patient is fit enough, we use this approach. Now complications are, there are many, but I will just mention few. Number one complication, that it on the way you may damage the cerebellum, or you damage the 8th nerve, or you may damage the 7th nerve. So simple, I told you be careful on the way. So it's so simple that damage to the 7th nerve, which is facial nerve, if that is damaged, patient will develop what? Facial nerve? Facial paralysis. Patient will develop paralysis of, and half of the face will be paralyzed, and you know half of the face is concerned, or rather facial muscles are concerned with muscles of facial expression. Is that right? So 7th nerve damage, then 8th nerve damage. And 8th nerve is very important nerve. It is concerned with your auditory function and also with balance function. Right? Am I clear? So if there is 7th nerve damage, this is one complication. Other complication which can occur is 8th nerve damage. Then on the way, cerebellum damage, cerebellar damage, or stroke. When you stroke is a permanent neurological damage to a part of the brain, right, due to vascular event. Maybe when you lift the vessel, this vessel had a small branch going to some area, and that branch is ruptured or that is avulsed, and that may produce stroke. And then of course there can be infections, right? And then a special type of side effects which occur in such surgeries, that is that if your dura mater is not properly closed and there is, what is there? Leaking of cerebrospinal fluid. Post-operative, there is, we call it CSF post-operative CSF leaking syndrome. So these are the complications which can occur, and one of the complications is death. So you have to take care out of, even though that is not very common, but that is there, right? So you have to be very careful that which patient you are approaching, and patient is physically fit for this operation or not, right? But still it is considered one of the best approach, rather the best approach in the properly selected patients, right? It's most widely used and it gives immediate relief from the disease, right? Most of the patient after the operation, people who really don't get complications and they are happy with the results, they say, oh, we should have gotten this operation earlier. Is that right? Of course, someone who got complication won't share the opinion in the same enthusiasm, right? Then we come to the next approach, right? This is about microvascular decompression, most widely used. Best results are in classic tick-like symptom. Is that right? And patient should be physically fit enough to go to such kind of surgery. Is that right? And post-operatively you must do, pre-operatively you must do high resolution magnetic resonance angiography to just delineate, to know exact relationship between the artery and the nerve, right? And then you have to avoid all these complications, right? Clear? Then we come to next approach. Next approach, which is percutaneous radiofrequency thermal rhizotomy. What does it mean? Percutaneous, you go through the skin. Look, it's really not a major surgery. It is invasive, but not like that fashion. In this case, what you do, through the cheek of the patient is heavily sedated or under general anesthesia. This is done in patients who are very old or who are frail or whose life expectancy is relatively less, who are not fit for this procedure, right? Who are not fit for the MVD. But of course, we need to provide them pain relief if drugs fail. One of the approaches, even though now it's used less often, that we pass a needle through the cheek and it is pushed upward while visualizing the needle under fluoroscopy. On the screen you can see the needle as it is approaching, and you take it to the foramen ovale, right? Let me tell you exactly what is going on there. Here is this nerve coming. Here is compression. Right, and there was your ganglion which was producing symptoms. Now, here is motor root also. Motor root of trigeminal, which supplies the muscles. And here is your foramen ovale, right? Through which, yes, and motor root comes out, and this is going out of the skull through foramen ovale, mandibular division. And what was this division? Yes, this was going out through foramen rotundum, and this was going out, actually its branches. This is ophthalmic division, which has its own branches. There is lacrimal branch, there is frontal branch, and there is nasociliary branch. They enter into orbit through the superior orbital fissure. Is that right? And this is foramen rotundum. Now, actually, we approach this ovale, that through the cheek a needle goes, we push a needle which is going through that, and this will go through that, and it should end up into what? Ganglion. This should reach to the ganglion. So we pass a needle under fluoroscopic guidance and we push it through the foramen ovale and approach the ganglion. Now it's very important to understand. Here we are not removing the offending blood vessel. Patient is not fit enough for that kind of surgery. So just through a needle we try to manage the thing. What we do? Needle tip, it is having radio frequency waves are released here, and they produce high temperature here, and that temperature, right, produces a thermal lesion here, thermal injury to the ganglion or thermal injury to the nerve. But usually from here you reach to the ganglion, because ganglion is just sitting with its ass on the foramen ovale and you are approaching from there. So you produce a heat energy here, thermal, Rhizotomy, sensory fibers are cut, damaged. So what is it? Percutaneous, to go through the skin and produce a radiofrequency thermal injury, or by thermal mechanism cut down some of the fibers of the sensory nerve. Dorsal root sensory fibers are called, cutting of those fibers is called rhizotomy, right? So this procedure is done. You produce a thermal lesion and then pull the needle out, of course, right? Of course, this procedure is not as invasive as MVD, as microvascular decompression. That is why that operation is used in very elderly patient, a patient who are not physically fit for microvascular surgery, decompression, or the patients who have short life expectancy due to some other reason, right? Now, the thing is that even though after this kind of, here you have not, again I will stress, you have not removed the offending vessel, you have damaged the nerve fibers which were taking the pain sensations. So no more pain attack are there. No more pain attacks are there. So this type of procedure gives a short-term relief, number one. Number two, recurrence rate is that within, you can say 1 or 2 years, 30% patient again get the problem, right? And the worst thing is that sometimes those fibers which are taking sensations, touch, pain, temperature sensations from the face, right? Those fibers which were taking touch, pain and temperature fibers from the face, those are inappropriately over damaged. And when too much fibers are damaged, then from this part of the face, sensations cannot go back. And you develop a sort of facial numbness. What is the side effect? Major side effect of this type of percutaneous radiofrequency thermal rhizotomy is that you overdo your work, and then a part of the face, or sometimes unfortunately half of the face, develop numbness. It is that kind of sensation, numbness, when you are going under dental procedure and they produce an anesthesia, you feel that part of your gums become numb. In the same way, in this, facial numbness can occur. Zara, you need to explain this to the patient earlier, right? But of course, patient is spared of more dangerous complications. Is that right? Yes. Is it clear? Now this procedure is less often used. Another new modality has come into action. That is gamma knife radiosurgery. While I'm writing it, the third option, gamma knife radiosurgery, I must tell, this is not a surgery. It is not a surgery. Okay, before I go there, one more thing. You know, when we are doing this procedure, we are passing in very intimate relationship with the motor root, which supplies the muscles of the jaw, muscles of mastication. If you do this operation bilaterally, it may damage the motor root of, what is this? Motor root of trigeminal system, and muscles of mastication and jaw may be weakened. That is one more complication if you do it bilaterally. But let's go back. Now some good news. Good news is that now if the facility is available, if gamma knife radiosurgery unit is there, it is also a very good option, right? The good point about this gamma knifing is that, number one, it is not surgery in conventional sense. I will tell you what it is, but it is not surgery. No cutting is involved. The beauty is this, no cutting is involved. Of course, then no pain is involved. Good news, isn't it? Even though we call it gamma knife, actually even though no knife is involved, even there is no knife is involved, in that kind of knife is not there, right? Classical knife. So gamma knife radiosurgery, there is no surgery involved in a conventional sense, there is no cutting involved, no pain is involved, right? Then what is involved? Let me tell you what exactly it is. Let's suppose here is your patient, and here is your neuron. I will tell you exactly what is this procedure. Here is your blood vessel, and I must make anterior cranial fossa, middle cranial fossa, posterior cranial fossa, right? And here is cerebellum, and here is your beautiful skull, right? And you have other things also there, pituitary gland, and I will not go into detail, and cerebral hemisphere. Okay, I will put the skull around it with a different color. This is anterior cranial fossa, here it is middle cranial fossa, and after that here it is posterior cranial fossa. And now, and there is your beautiful nose, and with other accessory structures, you know, you have, and here is your orbit, eyeball. I think we should take the nose a little down so it should look a little more nosy. Okay, so this is, now somehow we have to reach here and do something here. Now what is that something? Ideally lift the vessel, but for that you have to reach there, and procedure is MVD, right? Second procedure was you take a needle there and damage this. Now third is we go for gamma knifing. Now what is gamma knifing? Gamma knife radio surgery. Actually in this case you put a special type of frame around the helmet, special type of helmet around the head of the patient, or we call it a frame, right? We fix the patient head, because patient should not be able to move his head. We don't want that our knifing goes wrong. We fixate the head, then through a special machine, there are cobalt radioactive rods, right? And these radioactive beams, they are focused on from multiple angles. We focus on the tissue of our interest. Now, what is the advantage? That when a single beam is very weak, it does not damage our tissue, brain tissue by radioactivity. But when all of them are focused intensely, they are able to cut the tissue and damage the tissue. So on the way, all tissue is preserved, there is no damage. But the point where they focus, imagine a lens which focuses the sunlight on a spot on paper. You can burn the paper. But where they are on the way from the lens, when, okay, let's imagine here's a lens and here's a paper. If sunlight come in parallel and it reaches here, here it will produce the burn. But on the way here it cannot do anything. In the same way, these radioactive beams, individual beams are weak and they don't damage the brain tissue or other tissue intervening between the target and origin of the radiation. But we focus in such a beautiful way that here they start damaging, and these beams damage the nerve fibers here, either in the root or in the ganglion. And the beauty is this, now they are discovering that pain fibers are more susceptible to damage than other fibers, right? And of course then pain attack cannot go. Now this procedure is very good procedure. Why I am saying it's very good procedure? No cutting is involved, no bleeding is involved, no type of dangerous complications are involved. Is that right? And it's a day procedure. It's a day procedure. You go to the hospital, they refer to you. If eventually they made decision that you should go under this therapy, they refer you to the gamma knife radiosurgery unit. You reach there, they will put a helmet there and then put your head along with the helmet in a radioactive machine, very big machine. Only problem is claustrophobia, right? For 1 or 2 hours, focus the beam and they produce a damage here. Now, there's one thing common in this procedure, gamma knifing, and also in radiofrequency thermal. In both cases, you are not removing the offending vessel. You are damaging the nerves, nerve fibers. Is that right? This has very good advantage that it has least side effects. But the only problem is that it is less efficacious also. The day patient goes home, most of the patient don't get relief immediately. This lesion keep on cooking here. It keep on working here, and relief come from the attacks of trigeminal neuralgia. It takes over many days or weeks, sometimes up to 3 months. Right? It's a gradual improvement of patient condition. Number two, in many patients, recurrence may come, but thank God we can also repeat the procedure. We can again repeat the procedure. So these are 3 surgical, you can say, approaches or non-pharmacological approaches. Again, I will repeat microvascular decompression. In microvascular decompression, what you are doing? You are doing major operation. It should be done in more physically fit patients. It gives the best results, especially in classic tick-like symptoms in patient, right? And then we come to percutaneous radiofrequency thermal rhizotomy. In this case, through the cheek, you pass a needle through the foramen veil, approach, what is this? Ganglion or nerve root. In past, not now, in past we used to inject glycerol here. Glycerol can also damage this tissue, right? Or in some books you will remember, sometimes through the needle they pass a small balloon, and this balloon will actually lift this vessel up. But these days we prefer to give radiofrequency rhizotomy procedure. Through the needle we do radiofrequency damage to the nerves, right? Major side effect here is facial numbness, and this procedure is best suited for those patients who cannot undergo major surgery, MVD, but they can tolerate this procedure, right? And now we are having gamma knife radiosurgery as well, which is truly no surgery, no cutting involved, no bleeding involved, no pain is there. It's a day procedure, right? You put a helmet and you put a machine. You have put the head with helmet in the machine, and you focus the gamma rays, cobalt, radioactivities, beams, gamma beams, beams concentrate on the target area and produce injury there. The response comes gradual. This is less efficacious procedure. Recurrence is more common, but procedure can be repeated, right? So that was all about. And remember again, in patient who are having multiple sclerosis, clinical features, in a patient with MS, multiple sclerosis, remember, when a patient is younger or patient has bilateral trigeminal neuralgia, think of multiple sclerosis. And if you diagnose that his trigeminal neuralgia is due to multiple sclerosis, please don't think of any kind of these procedures. Is that right? Because problem is not because there is some blood vessel or something. Problem is that simply autoimmune process, T cell mediated demyelination of central fiber is there, especially fibers which are very near to the entry zone, right? In those cases, of course, we'll treat the patient as the patient of multiple sclerosis, and that we will discuss when we'll have a lecture on multiple sclerosis.